Hello, this is one in the series of lectures by the Functional Movement and Fitness Corporation, or C's Health. This one deals with the issue of why do we need actual practitioners, doctors, NPs, or PAs in fitness centers. It also, and why do we need specially trained practitioners with a special skill set? Um, it's going to also be the answer to the question, why do we need a division of specialized physicians to correspond to orthopedics, which I'll get into. The COVID pandemic, which we're going through right now at the time of this video, is illustrative of it, as I'll get into. In 2016, I left full-time work at Harvard after a quarter of a century to form the Functional Movement and Fitness Corporation to address, among other things, um, this issue. In part, with this was to develop practitioners not just trained in medical urgencies, but um, when it comes to the musculoskeletal system, knowing injury prevention, physical exams based on the kinetic chain and neuromuscular dysfunction rather than looking for things like ACL tears or rotator cuff tears. Um, they also need to have a background of in as being a personal trainer or an athletic trainer, because an important part of this is that the patients are ultimately going to go to fitness centers, and you need to be able to communicate with the trainers. My name is Mark Brezinski. I decided to use a new picture. I mean, this is my background. You can look at it extensively. Harvard and MIT, 1988. Most of my time was spent between Brigham and Women's and Mass General. My I'm an internist and cardiologist, but since 2000, and I had begun it before then, I became officially part of the orthopedics department at Harvard. And My training has been PhD in exercise physiology, orthopedics uh, training for 17 years. I got certified in exam skills from physical therapy, worked with the University of New England in osteopathic medicine, but most critically worked in functional movement, which I'll address on the next slide, and you can read the rest of it. I'm sure you're not here to read it, and actually I put these slides out of order. I apologize, but the um, the two things we need to address in these fitness centers are first, we need to address musculoskeletal disease in terms of the kinetic chain and neuromuscular dysfunction rather than looking at injuries. And I'll go into why we do exams based on looking for injuries, McMurray's test, sliding door test. Those are all injury searching tests. People don't know, very few people know how to prevent injury. So we want to increase function with age, non-surgical injury restoration, and injury prevention. But the other issue, which I'll get into, is the answer. You look everywhere. What do you do with chronic disease? And it's put them in a fitness center, have them exercise 30 minutes 5 times a day. Well, you actually need to be trained in these areas how to address obesity, hypertension, cardiovascular disease when it comes to fitness. Diabetics usually don't get chest pain, so on a treadmill, how do you recognize a heart attack? We're, I'm dealing now with COVID patients needing to get back in after they've had their blood pressure, heart rate, oxygenation all over the place. How do you get them back into a fitness program? This is all medical, or even how do you clear them to be back at the fitness center? This is a slide that I put out of order. Functional movement I learned from a whole range of areas, and these are among the people I've learned from. Tom House on the bottom, the person who, Tom House is great. You probably have seen him. Um, they made the movie $1 Million Arm about him. Uh, Kibler, the orthopedic surgeon who coined the phrase kinetic chain, Emily Spickler, the podiatrist. And these are all people who I've learned a lot from uh, in studying their work. Now, here's one of the cores of the problem. So if we look at neurology and cardiology, they have medical branches corresponding to the surgical branches. So there's neurosurgery, cardiac surgery, there's neurology, cardiology. And this affects the musculoskeletal field in two major ways. First, that the exams are surgically based because there isn't a corresponding medical division. You don't expect cardiac surgeons to be experts in heart sounds, the cardiologist does, but it also shifts dramatically the research. So we're only now seeing a lot of evidence based research in musculoskeletal disease, but it's coming from all different areas and all different fields in a very sporadic way. And I'll get into some of these points later in the talk, and I'll try not to make this too long. And then it's really important to have a background and training. So what's driving this? What's driving it is the high costs associated with um, chronic disease treatment. Um, Patients with chronic disease do better with exercise. Uh, and we're going to go into the fact that a lot of orthopedic procedures do not have as great of outcome as we previously thought. And we have an over reliance on imaging, which is going to be related. And outcome monitoring has become important for reimbursement in musculoskeletal disease. And the questions are coming up. Does rotator cuff surgery, is it actually beneficial? Meniscal surgery, is it beneficial? Yeah, I was hoping to put this in the presentation twice. This is understanding Michael Porter. I want to bring up Michael Porter, who, along with Peter Drucker, are probably the two most famous authors for Harvard Business Review. But, Michael Porter, in his works, points out constantly that straddling doesn't work. If you think that you're going to add this on to a separate field, if you're going to train somebody who's specialized in one reason with some skills, that's straddling, and it's only um, it's a recipe for disaster. And so you actually need to train people specifically for this function. So why do providers need to be well trained in medicine beyond musculoskeletal disease? So again, many professionals are excited over the concept of chronic disease going to fitness centers, but aren't accounting for the challenges of the fitness centers actually handling these patients. It will reduce healthcare costs and it will improve patients' quality of life um, and likely mortality. In addition, medical systems will need to develop their own um, fitness centers to a specific design, and that's dealt with in a different cost, or have control over the centers because there has to be integration. Physical therapy only lasts for a period of time and then patients go to the gym, and there has to be coordination with the fitness center. So we look at diabetes, and uh, the statement's been made that this newest generation is going to be the first generation that's going to have a lower mortality than previous generations uh, in recorded history because of um, the high incidence of diabetes, and that's predominantly related to high BMIs. Um, and so we need to be addressing these patients in fitness centers. I mean, what do you do with a client who wants to weight lift but is on antiplatelets or anticoagulants? What do you do with a COVID patient 5 weeks out? So, an organization that's worked on this, though, at least in part, putting fitness centers in approximation to clinics has been the Fitness Association. And they have had some degree of success, and I recommend looking at their work. And companies are coming up with smart machines and more integration besides doing things like hemoglobin A1Cs in the fitness center. Smart machines where you can walk, trainers or personnel can walk around with a card. The patient comes in with a card. You can plug it in to the treadmill. That data is recorded, and the PCP can actually monitor how much exercise the patient actually did, or the trainer in the fitness center can note the patient is depressed or upset over something, and this information is directly transferred back to the PCP. So, preventing musculoskeletal problems. The current exam is designed, it doesn't matter if you look at PT, athletic trainers, orthopedics, the design is around predominantly identifying musculoskeletal problems. I've trained in these various areas. I know how to do a sliding door test. I know how to test for um, uh, a rupture of the supraspinatus. But we want to prevent this. And when we get to the supraspinatus, this is dealt with in another lecture. It's all about strengthening serratus anterior rather than waiting till it actually ruptures. But again, that's dealt with in a different presentation from back in 2016. So most specialties, if not all, are trained to identify surgical problems, not prevent injury. And you're going to, starting a few years ago, you started seeing everybody mentioning the kinetic chain and this mentioning part. So we use the kinetic chain. So we're addressing scapular dysfunction, but they don't actually seem to know what it is or how you use it or what you do with the information. And that's a problem. And if you watch a lot of videos carefully, that sort of sticks out at you. So medicine, this is just a couple of examples of medicine in the wrong direction. So this was a New England Journal of Medicine done at the orthopedics department at Harvard while I was there. Um, and Katz is obviously a brilliant um, clinical trials expert. Unfortunately, we have only a small number of people in the musculoskeletal field who can run large-scale clinical trials, but he happens to be one of them. But when they looked at um, patients with meniscal tears, uh, those who just had physical therapy did better than surgery in physical therapy. But you can read the results yourself in the paper, and there's been numerous papers after this, but it was somewhat self-evident, and I was one of the people pushing for this study. It had it, it did the evidence was pointing at it for like at least a decade. And this is one that goes back. This is paper is from 2011, but back in the 1990s, it was already becoming clear that imaging studies don't predict back pain, and that's because back pain isn't usually caused by the back. Now, there are red flags, things you worry about like tumors, fractures, a variety of other things that you have to make sure aren't there. But we're going to go into the kinetic chain. Back pain is usually caused by a failure in the kinetic chain, which I'll get to. It's something going on below the waist. It's usually gait or sitter's disease. And I'm going to get into that in a minute. So the fact that imaging studies don't predict who has back pain and who doesn't isn't exactly shocking. Now, the other thing, and I drive this home with medical students, imaging and blood tests, they support diagnosis. They rarely make diagnosis. So in this study from 2012, they took median age asymptomatic patients, median age 38, and did MRIs of their hips, and 73% had something you could operate on. So if you imaged it, you found something you could operate on. So let's say the patient had symptoms um, that were radiating from another area to the hip. If you do an imaging study, it's going to show a, a labrum tear, and then somebody's going to end up operating on it. And one of the examples I often use with medical students is a abdominal image that shows an increased size of the, somebody comes in with abdominal pain, increased size of the aorta, they have gallstones, and you say to them, well, which is what's causing the abdominal pain, and the debate between the gallstones and the aorta. And the answer is the patient has ulcers, and you would get that from the history and physical. 95% of all diagnosis is from the history and physical. And same with this image. And when I see these MRIs of the spine, they make my stomach curl because people come in and hand them to you. I actually have a YouTube video for incoming patients, and yes, I am predominantly an inpatient doctor, internist, hospitalist, intensivist who was trained in as a fellowship in cardiology. But outpatient, I do musculoskeletal, and that's becoming more common. Cardiologists doing musculoskeletal. But with this particular image, the the patient will ask you, do I have spinal stenosis? Spinal stenosis is a clinical diagnosis. Um, and I want to differentiate. This is low enough that you would actually be doing quadricoin anyway. But let's say it's above L2. So, hyperreflexia, Babinski's sign, muscle weakness bilaterally, that would be signs of spinal stenosis. If patients had nothing on physical exam and history, and they just have an image that suggests spinal stenosis, that's just radiographic spinal stenosis. So this is all where medicine is off track in the area of musculoskeletal disease. So we're going to base our exam, and we do base our exam on the kinetic chain and neuromuscular dysfunction, and this is covered extensively in lectures or presentations on YouTube dating back to 2016. People who follow our channel or our company know this image well because I love to use it. On the left, you have somebody who's everted their foot. Now look at all the maldistribution of cartilage uh, across the kinetic chain, with the exception of the ankle joint, and I'll get back to that in a minute. So now imagine on average the patient walks 5,000 steps per day. So over a decade or two, they're going to have asymmetrically hammered on that cartilage up and down the spine. It will cause back pain. It's going to cause a lot of problems. This is simple um, eversion. So gait is one of our most critical areas, but it's not the gait that's typically examined. Most people follow the center of mass, ataxic runner's gait, ataxic gait, Parkinsonian gait. That is not what we're talking about. We're talking about a gait exam designed to follow for destructive cartilage changes. And the other part of it is Sitter's disease, and this is from the brilliant book by Newman and the other editors, um, The Kinesiology of the Musculoskeletal System. I highly recommend this book, but it shows what either tension in the flexors or tension in the extensors does to the spine. So this image is actually covered in depth in the kinetic chain video, so I'm not going to go into it here. But both of these tight flexors or tight extensors will lead to back pain. Hopefully, if you have time, go back to the kinetic chain lecture. So now, this patient comes in with knee pain. We take an image, the image is abnormal. Is that the cause of the knee pain? Now, from our perspective, we look at the kinetic chain, and sorry, but one definition of the kinetic chain is you can't view joints as being independent. So the knee is one of the most dependent joints there is. It's dependent on the function of the hip and ankle um, almost exclusively. I mean, it can be viewed as being held hostage by the hip and ankle, and most knee and hip injuries relate more to the hip and ankle. And so, in addition, it's heavily dependent on on the neuromuscular components, dynamics, and proprioception. So I'm going to take this patient with knee pain, and hopefully this video plays. Now, if the patient had gotten a complete exam, a functional movement exam, a test like a single leg squat would have been done, and these are the results. You can see that the knee is unstable, and this is due to problems at the ankle and or hip, and it's not due to problems at the knee itself. So now imagine that patient starts going up steps. That knee is wobbling all over the place, and it's not a shocker that there's knee pain, and it has nothing to do with those findings on the radiographic exam. So I just want to go briefly into neuromuscular. So ankle sprains, this study was from 2014. I'm going to summarize it briefly. If you have a lateral ankle sprain, you have a 70% chance of recurrence, but the 70% chance recurrence is in either ankle, and it's due to neuromuscular changes, primarily in the gait. So if your focus is on the ankle the whole time, the patient's just going to keep getting ankle sprains. You've got to consider the whole patient, the kinetic chain and their neuromuscular function. So again, we need to design around tailing toward a need. We're not going to give people skills, try to add on skills to people trained in other areas, which is known as stratoing. The fitness centers need to be in direct contact with the fitness center. Um, and so this slide, sorry, I just want to use one more example, is that um, that why do people get ACL tears? And so there's several studies that have come out, and the answer is, in a large number of cases, proprioception. So if you look at skiers, this is the example I use most commonly. I have skiers do a single leg squat with their eyes closed for 20 seconds, or not even squat, just stand on one leg with their eyes closed for 20 seconds. And some of them can't do it for 2 seconds. So when you decelerate while skiing, you need precision contraction of the hamstring, of the flexors and extensors at the knee. If the patient turns their head, and remember, we know where we are in space because of the inner ear, the eyes, and proprioception in the joints. If their joints are feeding poor proprioception information, and you take away their eyes, those muscles, the amount that each group contracts will be inaccurate. And so the patient is going to end up shearing the knee and tearing the ACL. This is one of the most common mechanisms for ACL tears. So there is a failure of the traditional exam because the traditional exam is designed to find surgical problems. And this slide, this is actually my mother, who was a famous fitness instructor before she died in a car accident, um, and it was one of the reasons why I went into this. First of all, we again need to integrate with fitness centers Patients can only do physical therapy for a short period of time, and healing takes longer than that. And physicians in this area need to be able to communicate with the trainers. They need to be able to outline um, a fitness program. But also, it's a tough area of medicine. As a cardiologist, when you say you want to put in a stent, patients say, okay. Convincing somebody to exercise is an art. You have to create an experience. And I learned this from my mother. My mother was very dynamic, much more than I am. And she engaged people and filled her classes. And so it's getting people into these fitness centers and requires this additional skill. So, you know, in summary, why do we need specialized people? Because we can't just add the skills onto anybody in the current profession. I mean, we can take cardiologists, we can take internists, we can teach them the functional exam, but we need people who have a fixed set of skills. They need to be or nurse practitioners or PAs. They need to be able to handle both medical problems and medical emergencies, but they also need to be trained in the functional exam and not the surgical exam. This is from Marblehead, Massachusetts, where we're based, and I thank you for your attention.